Natalizumab was approved in 2004 and was looked forward to with great anticipation because of a new mechanism of action and very early data which showed dramatic efficacy. The FDA actually approved it on the basis of the first year's data of a 2-year trial. So in the original trials of natalizumab, the reduction in the relapse rate, which is one of our measures of efficacy, was over 60% reduction in relapse rate. The MRI parameters are in the 90% rate reduction. And the disability numbers, which are always hard to compare or think of, were also more profound than in the other medications that we had at the time. So natalizumab inhibits the binding of the white blood cells to various molecules on the surface of the bloodstream, which drag those white blood cells out of the bloodstream and into the brain and spinal cord. And so natalizumab's effect is to inhibit that egress or that exit from the bloodstream getting into the brain and spinal cord so that it both limits the positive effects of the immune system, but it also limits the abnormal immune response from getting into the brain and spinal cord. 2 patients who were involved in the original research trial, who were at about 2 years of therapy where the trial was ending, now came down with a condition called PML, which involves an infection and inflammation in the brain, which we hadn't seen before in patients with multiple sclerosis. It's a higher risk and a worse type of problem than we have with most of the other multiple sclerosis therapies. I should say that PML is an infection in the brain that causes demyelination, much like MS, only worse. It's caused by a virus that lives in most of us, but somehow when our immune system is impaired and a number of other parameters occur, the virus gets out of control, infects the brain, and causes a very bad problem. So we know that PML can occur in many other immunosuppressive states, and that includes many immunosuppressive medications. But for reasons that aren't perfectly clear, it's higher in patients who receive natalizumab than in many of those other medications. And so the drug was taken off the market in 2005, and the FDA and the pharmaceutical company and the National Institutes of Health did everything they could to define what that risk was. Was there a way around it? Was it the drug that actually caused the problem? To learn everything we could. The drug was brought back to market in roughly 2006 because of the very profound perceived efficacy that patients and doctors alike thought that although there was a very significant risk, that the benefit of the medication warranted having it available. And then over time, we've used the medication more and more as we've learned better how to stratify the risk, who might be at greater risk for this condition called PML and who might be at lesser risk. So natalizumab is infused as a every 28-day infusion, 300 milligram infusion over about a 1-hour period. So patients or people with MS that utilize natalizumab generally go to an infusion center every 28 days to get their infusion, the total time of which is a few hours. The TOUCH program, which is a program instituted by the pharmaceutical company and the FDA to monitor how natalizumab is used, mandates that the patient be observed for a 1-hour period after the infusion. So it's a very elaborate program to try to monitor for difficulties and to try to make sure that everybody involved understands all those risks and is dealing with them appropriately. We have a few patients who mention that they get a headache or they're a little sleepy afterwards, but many of the patients leave their infusion and go about their normal activities during the day. As with any infusion of proteins or large molecules, there are a small number of patients who can have a profound anaphylactoid reaction where they have blood pressure drop or things, but those are really very uncommon. So with the treatment with natalizumab, we test the CBC with differential to look at the white blood cell counts, and we check liver tests, again, to make sure that the patient does not have issues with regard to their white blood cell count or their liver prior to initiating therapy. Most of us check a white blood cell count and differential periodically. The FDA really recommended checking liver tests if there was some signs of liver disease or other problems which could indicate liver disease. It turns out that some people produce an antibody that's directed toward the JC virus, which is the causative agent of PML. We don't know why. Some people produce that antibody and others do not. Most of us also check the JC virus antibody ahead of time to better understand at what risk this particular individual would be if they were to choose to use natalizumab therapy. Most of us would monitor that antibody level approximately every 6 months because we do know that some patients or individuals change their antibody status over time, and we think that correlates with their subsequent risk of developing PML. We clearly know that producing that antibody doesn't protect from the development of PML. In contrast, it actually is a marker that they're more likely to develop PML than individuals who don't produce that antibody. Over time, we've come to understand that it's not black or white in terms of risk, but rather that there's a gradation of risk. So we believe that some patients may have a risk that's less than 1 in 10,000, and others may have a risk of developing PML of 1 out of a few hundred, depending on this antibody index, the duration of therapy with natalizumab, and also whether or not they've previously received immunosuppressive drugs, which we know also increases the risk for further development of PML. Natalizumab, like most of our drugs, is category C, which means that we don't have substantial evidence of its safety or during pregnancy. With most of our multiple sclerosis therapies, we generally suggest that women decide to discontinue their medication prior to becoming pregnant. So the decision over which MS therapy to choose is a complicated one. It's a very individual one, and it has to be a very considered one. We all understand our best prediction of this patient's disease, risk of treating aggressively or not treating it as aggressively, and the various options in terms of their benefit, risk, and tolerability. Having said that, the decision to initiate therapy with natalizumab is generally when the patient and the physician decide that the added benefit in terms of how well the medication works is enough to warrant whatever greater concern there is about the risk. So when I think about washing out from natalizumab and changing to a different therapy, there are a number of issues that guide my judgment in that regard. One is that we have quite a bit of data that suggests that when we stop natalizumab therapy, many patients will start having relapses again after 2 or 3 months. We also know from more scientific or biochemical data that the effects of natalizumab, even though that natalizumab is out of your system, that the effects are there for 6 weeks or so. So it seems to me a reasonable approach is to wait a month or 6 weeks or 2 months, but not longer. So now, because we have so many treatment options, often the choice of which treatment to use can be overwhelming. It's often complicated at the time of diagnosis because the diagnosis itself is overwhelming. It's the role of the MS healthcare provider to make it less overwhelming, and as best we can to share our understanding, our impressions, our hopes, goals, and our choices if they're interested.